Hello, I'm Dr. Michael Niederman, Clinical Director and Associate Chief of Pulmonary and Critical Care Medicine at Weill Cornell Medical Center and Professor of Clinical Medicine at Weill Cornell Medical College. Today, I'm going to talk to you about aerosolized antibiotics for ventilator-associated pneumonia, updated for the current year. Listed here are my financial disclosures. We face many challenges in the treatment of pneumonia in the ICU. We're dealing with increasingly resistant gram-negative bacteria, and although we have new systemic antibiotics, many of them have not been shown to be superior to older drugs by the nature of the way in which the trials have been designed. And we need to avoid overuse of systemic antibiotics. Use of adjunctive inhaled antibiotics is one way to achieve these goals and effectively do more with the current armamentarium we have. We want to expand the use of adjunctive aerosolized antibiotics because in the past they've been only used anecdotally as salvage therapy for VAP due to MDR pathogens. To get true maximal benefit from aerosolized antibiotics, we have to optimize their delivery, and the delivery system is not what once existed in the past. The data I'm going to go through today show value of adjunctive aerosolized antibiotics in leading to less systemic antibiotic therapy, allowing more de-escalation in the therapy of VAP, and allowing for less antibiotic resistance to emerge. I recently wrote in Frontiers in Medicine a review article about the place of aerosolized and adjunctive nebulized antibiotics in ICU infections, and particularly VAP, and I'll refer you to that for more details. How do we optimize delivery of antibiotics to ventilated patients? We have a number of different ventilators we can use, which I'll go through in a moment, but the preferred delivery method is a vibrating mesh nebulizer, and I'll talk about that in a moment. We have to also think about what we do for the ventilator, and there are a variety of different ways to deliver the aerosol in a ventilated patient. We can do it with a synchronized inspiratory delivery system, which we used in the trial that I'm going to discuss, or if you want to do it in a non-synchronized fashion, you need to limit the inspiratory flow turbulence. That means we use the control mode of ventilation, not the assist mode, and we may need to sedate the patient. We aim for a tidal volume of 7 to 9 mils per kilo, constant inspiratory flow rate, minute ventilation less than 6 liters per minute, an IE ratio of 1 to 1, and maybe even a greater inspiratory hold. And again, that inspiratory pause should be 20% of the duty cycle. We remove the HME filter, and we add humidification if the delivery time is greater than 30 minutes. This is very, very nicely described in the reference here by Ruby and his colleagues. Summarized from my article here are the types of nebulizers available. The ultrasonic nebulizer is a high-frequency piezoelectric crystal that delivers drug, but has the downside, if you will, of maybe overheating in the drug solution. The jet nebulizer creates a Venturi effect of compressed gas, but there's a large residual volume that can interfere with the ventilator. And the preferred delivery system, as I mentioned, is a vibrating mesh system, which is a high-frequency mesh vibration in a drug solution. It delivers particles less than 5 micron in size, and greater than 60% of the dose that's put in the nebulizer actually reaches the patient. There's no heating of the solution during administration. And again, the only potential downside is it may take a longer time to deliver the full dose. In spite of our knowledge about nebulizer delivery, this very well done study did an online survey of over 190 ICUs and showed that frequently ICUs don't use nebulization. In fact, 87 ICUs of the 190 surveys use nebulization less than 3 times per year. And again, there were many mistakes that were made. Jet nebulization was the most common, and only 20% adhered to efficient use practices for the delivery of nebulized material. We first became interested in the use of aerosolized antibiotics in this study published in 2012, where in a prospective randomized controlled fashion, we delivered adjunctive aerosolized amikacin, 400 milligrams twice a day or once a day, compared to placebo in patients who had ventilator-associated pneumonia. 50% had Pseudomonas aeruginosa or Acinetobacter, and the delivery system was a vibrating mesh with a proprietary dose delivery system that coordinated the delivery with the inspiratory cycle. What's shown here graphically is that when patients receive the antibiotic twice a day, which is the red line, the amount of antibiotics that were used at the end of 7 days was significantly less if they used it once a day or if they used the placebo treatment. And so this demonstrated the use of aerosolized antibiotics as adjunctive to systemic therapy, led the investigators in this blinded study to feel the patients were doing well enough to stop the antibiotics earlier. And at the end of a week, with twice a day dosing, fewer patients were getting systemic antibiotics. There was more de-escalation in the twice a day group and more escalation in the placebo group. And so the aerosolized antibiotics seem to truly be reducing the exposure to systemic therapy. A subsequent study by another group of investigators showed that the use of aerosolized antibiotics actually reduced the rate of MDR pathogens in the airway, much more so than systemic antibiotics. And so the long expressed fear that aerosolized therapy was going to increase the frequency of antibiotic resistance was not realized in this study, and in fact, the opposite was shown. There have now been two very large studies of aerosolized antibiotics, which have unfortunately shown no mortality benefit. And this has been a great disappointment, but probably the failures of these studies are related to trial design. The first is the ISICEM trial, which was an inhaled amikacin phosphomycin study, where the primary endpoint was a change in clinical pulmonary infection score over time, and whether patients received inhaled amikacin phosphomycin twice a day for 10 days or placebo within 72 hours of getting systemic antibiotic, there was no significant difference in the clinical pulmonary infection score over time. There was no difference in mortality, clinical cure, but more microbiologic eradication with the amikacin phosphomycin inhaled system. The amikacin phosphomycin patients were on a mean of 6.6 days of gram-negative antibiotics at the time of randomization, which may have negated some of the benefit of aerosol therapy, but in a small subgroup who had a shorter duration of pre-randomization antibiotics, the change in clinical pulmonary infection score was significant. The other study was a study that I was the lead investigator on of inhaled amikacin adjunctive to intravenous standard of care in mechanically ventilated patients with gram-negative pneumonia. This study was published in Lancet Infectious Diseases in December of 2019. We enrolled 712 patients who got at least one dose of study drug. They were randomized in a double-blinded, placebo-controlled fashion. All patients had radiographic pneumonia, a clinical pulmonary infection score of at least 6. All were mechanically ventilated and had at least 2 gram-negative multi-drug resistance risk factors. They received no more than 48 hours of systemic antibiotics, and 508 had positive cultures. Amikacin was delivered via the mesh nebulizer with a delivery device that coordinated with inspiration, and the dose was 400 milligrams every 12 hours for 10 days, and patients received systemic antibiotics for as long as the investigator thought was necessary. The primary endpoint was mortality at 28 to 32 days, and there was no difference in the primary endpoint of mortality. If we look at the bacteria, there was a lot of Pseudomonas, more than any other pathogen at baseline. And when we look at other characteristics, most of these patients had hospital-acquired pneumonia or ventilator-associated pneumonia. All, again, were at risk for gram-negatives. And if we look at the frequency of MDR and non-MDR pathogens, we see a relatively high frequency of MDR pathogens in this study. The secondary endpoints showed that there was more eradication of Pseudomonas with amikacin inhaled than with placebo, but that did not lead to any survival impact. There was no survival impact related to any specific organism. There was slightly more bronchospasm, 4% versus 1% with the amikacin inhaled. But the real important issue in this study is the investigators used systemic antibiotic therapy for a mean of 18 days in both groups, despite the protocol encouraging stopping at 10 days. And I think that this is very important because it probably negated any potential adjunctive benefit of aerosolized antibiotics to reduce systemic exposure, particularly since everybody got so much systemic exposure. Ruby and his colleagues have criticized these negative antibiotic trials and recommended that future trials include more resistant pathogens, replacing IV aminoglycosides with inhaled aminoglycosides, not using a synchronized delivery system, but placing the nebulizer upstream in the inspiratory limb to act as a spacer type device as shown in this illustration, and to not trust the high epithelial lining fluid concentrations of antibiotics that we observed because they feel that a lot of those measurements are inaccurate and that even higher doses of inhaled antibiotics should be used. The IDSA and ATS guidelines recommend using inhaled with systemic antibiotics for MDR pathogens sensitive only to polymyxins and aminoglycosides. But on the other hand, the European guidelines do not recommend routine use of inhaled antibiotics. My view is that we should use inhaled antibiotics as adjunctive therapy for patients with MDR VAP when systemic therapies are used that penetrate the lung poorly, such as aminoglycosides and colistin, if there's a poor early clinical response, and maybe in ventilator-associated tracheobronchitis without systemic sepsis, where it might be used as monotherapy. So in conclusion, I think we should do more trials of inhaled antibiotics in VAP. Some small studies are positive. They do get more bacteriologic eradication, some clinical benefit, maybe less systemic antibiotics, but there is no reduction in mortality or more rapid clinical improvement. And I think the key has been we have to design trials in the future better. We need to use endpoints other than mortality, like clinical resolution, systemic antibiotic use, maybe microbiologic eradication. We need to limit prior antibiotic therapy duration, limit the duration of systemic antibiotic therapy to 7 to 10 days. And we need to define the optimal duration of inhaled therapy, optimize delivery methods, measure drug concentrations, enroll high rates of multi-drug resistant pathogens, and try to find an ill enough population that can benefit, but not those that are too ill, probably with an Apache score between 10 and 25. Thank you for your attention.